Around. So sepsis basic concepts. Well, to establish why sepsis is important, we wanted to include kind of some of the numbers here because they are quite staggering, right? Many people watching this video maybe had sepsis, know someone with sepsis, or maybe you're in the medical profession and you provide care for patients with sepsis. I know in my day-to-day, I see patients with sepsis, severe sepsis, septic shock pretty much every single day I'm at work. If I could just take a quick 60 seconds of your time, I wanted to introduce our newest WhiteBoard Medicine emergency and critical care community, and that is our Patreon community. Here we post emergency and critical care medicine medical education topics every other day. We focus on landmark trials, new trials, clinical pearls, bedside tips and tricks, and much more. Everything emergency and critical care. We also upload study guides for each video. We have practice tests, and our newest addition is going to be mini courses that kind of lay out video study guides, practice questions into an easily digestible form that we hope is very applicable and helpful to the bedside. Our goal is to try to get even 1% of our YouTube community to join our Patreon community. It would be incredibly helpful in allowing us to spend more time creating content and elevating our current content. We appreciate you all, and we hope to see many of you there. And that is because this affects 50 million people per year worldwide. And of those 50 million people, about 11 million of them worldwide die. If we focus on the USA, just because that's where we live, that's 1.7 million people in the USA. And these are probably old numbers. It's probably even a little bit more. So multi-millions of people every single year are hospitalized with sepsis. Apologies, let us mute that. In addition to that, of every 1,000 people hospitalized, about 15 of them actually will develop sepsis during their hospitalization, right? So about 15 will develop sepsis during their hospitalization. The vast majority of people who present with sepsis, but you are at risk of developing it while in the hospital, because obviously the hospital, as much as we try to keep it as clean and sterile as we can, certainly has, infections that can spread within the hospital itself. In 2022, there was $62 billion worth of sepsis-related care costs, and that was in 2022, so it's most likely higher now. So as you can see just from these brief numbers, right, it affects tons of people. Unfortunately, many people die from it. If you're hospitalized for something else, you have a risk of developing it while you're hospitalized, and then it costs billions and billions and billions of dollars every single year. So what exactly is it? What is sepsis? Well, really it's a dysregulated host immune response to an infection. So just briefly, we're going to dive into a little kind of immunology. When you have an infection, you have bacteria, which are going to be these little yellow guys that invade maybe your skin and cause cellulitis, or maybe they get in your lung and cause pneumonia, or they get in your bladder and cause a urinary tract infection. The way we fight those bacteria off, and it happens with viruses, fungi, parasites as well, the way we fight those bacteria off is with our immune system. Our immune system is literally made of cells that are programmed to attack and eliminate invading organisms. And that immune response actually starts with what we call the innate immune response. Those are kind of the first responders. And then after that, later on, the adaptive immune response. And we're not going to kind of dive too much into the nitty-gritty details, but as part of the innate immune response, there's kind of two major cells. There's many, many more cells involved, but the two major ones we think about are neutrophils and macrophages. And that's what we drew here in the green and the blue, a neutrophil and a macrophage. And what happens is these two cells, when they detect invading organisms like bacteria, is they find those bacteria and they kind of take it into their cell, right? And when they take it into their cell, it prompts them to start releasing a bunch of these kind of inflammatory mediators. So they release it kind of out into the tissue, and you get all these inflammatory mediators. Neutrophils do the same thing, right? And I'm underselling some of the complexity of this, but these inflammatory mediators do a couple of things. One, sometimes they're directly toxic to the invaders, right? Sometimes they directly kill the bacteria. They also recruit additional immune cells to come help them fight the invaders. Okay, another thing they do is they then kind of present parts of the invading organisms on the surface of their cell. And what those do is then they start to activate the adaptive immune response. And the adaptive immune response has some of the cells you might recognize more. T cells are a big one, and there's multiple types of T cells. B cells, which secrete antibodies, right? Antibodies people have probably heard of. And when you get vaccinated, kind of antibodies are what help protect you from infection later on, or if you've been infected with an organism, the antibodies keep circulating, protect you later on. So the innate immune response, it triggers the adaptive immune response, but it also locally causes more immune cells to come into that area to fight the invaders. It secretes these kind of cytokine mediators. Some of them are directly toxic to the bacteria. Some of them cause kind of this inflammation in the area. But in a normal immune response, right, because just because you have an infection doesn't mean that you're septic or develop sepsis. Sepsis only happens to a small subset of those with infections, because usually what happens, in normal, which we'll say is no sepsis, this is just kind of the normal fighting off an infection, is those anti-inflammatory mediators or signaling molecules are balanced with the pro-inflammatory mediators, because these immune cells, they secrete anti-inflammatory mediators as well as pro-inflammatory mediators, right? Because you need pro-inflammatory mediators to help fight off the infection, but you also want to balance that out. So these usually balance each other out in a sense so that this kind of immune response doesn't run rampant and run wild. Also in the normal response, you usually have some degree of locally controlled spread of these mediators. So right here we have a blood vessel, just call it a arterial. And what happens is some of these inflammatory mediators do kind of end up in the blood vessels circulating around, but the vast majority of them stay localized in the region of the infection, right? So there's some local control of the spread of these inflammatory mediators. In addition to that, these bacteria are going to prompt an immune response no matter where they are. So there's also phagocytosis, which is when the cells kind of envelope these bacteria, take them into the cell itself. There's a degree of phagocytosis of bacterial debris and the bacteria themselves, because the more bacteria that spread, if these bacteria or even debris were to get into the bloodstream, they'd spread to a bunch of different tissues and then prompt this crazy immune response. So there's some local control of that infection in that area. But what happens when this gets dysregulated, right? And dysregulation leads to sepsis. It's your own immune system that's becoming dysregulated. So what happens when there's dysregulation? Well, those pro-inflammatory cytokines and signaling molecules start to become kind of greater than the anti-inflammatory, and that leads to a higher kind of spiral of inflammation. In addition to that, the bacteria or even toxins the bacteria secrete start to spread, right? They start to kind of spread out of that local area. More of them will get into the bloodstream and travel to different spots, especially toxins that the bacteria secrete. In addition to that, there's some that feel that there's a genetic predisposition to sepsis, that there's something in people's genes that cause them to be higher risk for sepsis, probably something that affects their immune system. So sepsis is when you have an infection, but instead of having this normal response where your anti-inflammatory mediators equal your pro-inflammatory mediators, you kind of have some degree of local control over the spread of infection, you're getting rid of the bacteria and bacterial debris, you start to get this dysregulation where your immune system kind of goes into overdrive, it runs wild, and the pro-inflammatory molecules signal much more than the anti-inflammatory, which then recruits more immune cells, causing more inflammation, and you kind of see how that spiral starts to develop, and bacteria can spread into the blood or into other areas that causes then a more widespread inflammatory response, and certain people's genetic makeup might put them more at risk for this, but that's still kind of something being studied, which is why we put that question mark here. So sepsis is when you have an infection and then you get this, your own immune system kind of goes into overdrive, and your own immune system starts causing damage to your own tissues or organs, right? So what does sepsis cause? Well, it causes exactly what we talked about, a dysregulated immune response that then can lead to tissue damage, because all these inflammatory mediators, all these things that are meant to kill the bacteria, can also injure your cells. And when that is just localized to where the infection is, that damage is mediated, right? It's moderated. It's not allowed to kind of spread or run wild. But when you are septic, it starts to spread and run wild, and you get more tissue damage. And if that progresses, it can lead to organ damage, organ failure. It can lead to shock, where your blood pressure drops, and that can honestly eventually lead to death, which is why we kind of talked about that, the morbidity and mortality, right? Morbidity being You don't die from the disease, but you have some long-standing chronic problems from the disease, and mortality being you die from the disease. That's why these with sepsis can be so high, because when this starts to spiral out of control, you get organ damage, organ failure, shock, death. And that's kind of septic shock or severe sepsis, we often call it. So beyond that, when you are septic, when you have an infection and your immune system starts to kind of run rampant, what symptoms can you expect? Well, this is tough because it's highly variable and there's lots of overlap with these symptoms and just normal things, right? Let's say you have the flu, but you're not septic. You still might get fevers and chills and rigors. You might have a little bit of elevated heart rate, but that doesn't necessarily mean you're septic. It could though, right? And the things we most often see quoted are fevers, chills, rigors, which is where you're really kind of uncontrollably shaking, confusion or altered mental status, shortness of breath or breathing more quickly or labored breathing, an elevated heart rate. All these can imply that you're septic. And there's overlap depending on where your infection is, right? If you have pneumonia, you might have shortness of breath even if you're not septic. If you have meningitis, you might have confusion. Meningitis is an infection of the meninges that cover the brain, even though you're not septic. But when these all start to stack together, right? Let's say you have a bad skin infection or a bad urinary tract infection, and you start to get these other symptoms, you really should be worried that you could be developing sepsis. And again, if this progresses, right? If this progresses untreated and you're going into that severe sepsis where you start to get organ injury or septic shock, then you can start to get low blood pressure, hypotension, a weak pulse, and it can even lead to cardiac arrest if it spirals out of control and you get really, really sick. So the symptoms are variable and there's lots of overlap with other conditions, but if you start to get this kind of conglomeration of symptoms, you should definitely be worried and consider going to the hospital. And this is when we see patients that come into the hospital and they start to share some of these things, that they have a urinary tract infection. Maybe we detected it on a urinalysis, but they also have some confusion and some rigors and they're a little tachycardic. That's when we start to work patients up and diagnose them with sepsis, which we'll get into a little bit later. But these are the symptoms to keep an eye on, both as a patient and those that work in the medical profession of, all different areas in medicine, because you might come to the emergency department with sepsis. You might be admitted to the hospital for a heart attack, and then you're on the floor and you end up developing sepsis. You could be in the intensive care unit in septic shock, critically ill, something that we see in our day-to-day jobs. So these symptoms are important for everybody to be aware of. All right, the pathophysiology, and remember, this is the basics of pathophysiology. Pathophysiology is like, what is the actual kind of thing going on in the body, right? And we put three different pictures here. This here is a cell. This here is a liver, but we're kind of using it as an organ. And then this here is a heart, which we're kind of using for the circulatory system. We started smallest to largest, because at the smallest level, you start to get tissue damage and cell death, right? That's what's happening in sepsis. That immune system response has become so dysregulated, and you have so many inflammatory mediators that are causing your cells to die, right? Apoptosis is when the cell, it dies. It kind of, quote unquote, commits suicide. It kills itself. And that is, the immune system can signal those cells to commit apoptosis. It's meant to be a means to protect other cells. Let's say a cell has an infection or is struggling with that. If that cell commits apoptosis, or kind of kills itself, that infection might die with it. Autophagy, which is where the cell kind of eats itself. And then direct cytopathic being like a direct cell toxic mediators come out of the immune system. So those neutrophils, those macrophages, they signal cells to commit apoptosis. They signal cells to eat themselves and eat others. And then some of the mediators they secrete are directly toxic to cells, because bacteria at the end of the day are cell too. So the molecules that can kill those bacteria also can kill some of our own cells. So at the cellular level, we start to get cell death. When we start to get more and more cell death, it can lead to tissue injury and death. Our tissues at the end of the day are made up of cells, right? So if enough cells die or enough cells are injured, we can start to get some tissue injury. And this can result in organ failure, right? It can affect our liver. It can affect our lungs. It can affect our kidneys. We see patients in the hospital with acute kidney injury from sepsis very frequently, or hypoxia, respiratory failure from sepsis, or liver injury, transaminitis from sepsis. It can even affect our brain. That's why confusion is something we sometimes see, right? Lung shortness of breath is sometimes something we see. And this can lead to, at the worst, multi-organ failure, MOF, multi-organ failure. Okay, and if this keeps progressing, that's where we start to get the circulatory dysfunction. It can even cause circulatory collapse, right? We start to get vasodilation of the blood vessels, or the blood vessels start to dilate. And that happens from some of those inflammatory mediators, but also there's endothelial injury. The endothelium are the cells that line the blood vessel, and those start to get injured. We start to get microcirculatory dysfunction because the capillaries, right? We have arteries that go into smaller arterioles that go into capillaries and go into venules and veins. And we often think about kind of the arteries and things, but the capillaries, the smallest area, this is where you actually are getting blood flow to the tissues. These capillaries are where the kind of good stuff from the blood vessels comes out into the tissues, and the bad stuff from the tissues goes into the blood vessels, right? And it goes from arteries to arterioles to capillaries to veins and then back up to the heart and lungs. So you start to get microcirculatory dysfunction or dysfunction at this capillary level. And all of this can lead to that severe sepsis or septic shock, which can lead to morbidity and even death. So this is the pathophysiology, starting with cell damage, progressing to tissue injury, tissue death, organ injury, organ failure, circulatory dysfunction, and circulatory collapse, right? There's this spiral that can occur if we don't intervene. So if we're thinking about that, how do we manage it? And this is, again, just basics. Each one of these things could be its own 4-hour video. But for the basics, how do we manage it? Well, the first way to manage it is to diagnose it, right? How do we diagnose sepsis? Well, this is best done at the hospital. Whether that's with your primary doctor in the emergency department or what have you. And when we think about sepsis as a physician or anyone working in the medical world, any of that care team, whether it's a nurse or med student or resident or intern or physician assistant or nurse practitioner, respiratory therapist or medical tech or assistant or anyone that I forgot, definitely give yourself a shout out in the comments, and I will apologize for forgetting you briefly. But all of us are constantly thinking about this. All over emergency departments, there's kind of think sepsis plaques and things, because time to diagnosis is related to time to treatment, and time to treatment affects morbidity, mortality, right? Faster intervention equals better outcomes. So we have kind of this high index of suspicion for patients with sepsis, because as we said up here, symptoms are very nonspecific. So it's really tough to diagnose. And if we miss it, it can lead to much worse outcomes. So sometimes what we think about is SIRS criteria. SIRS stands for systemic, hopefully I don't forget what it stands for, inflammatory response syndrome. All right. And the SIRS criteria are the several different markers that can hint that someone might be developing sepsis. And those markers include an elevated heart rate, okay, an elevated or a low body temperature, an elevated or a low white blood cell count. Those white blood cells are your immune cells, and an elevated respiratory rate. And I am not going to write the actual numbers because we certainly could look those up and I might get them wrong. But high heart rate, high respiratory rate, high or low temperature, high or low white blood cell count. And if you have kind of 2 of 4 of these, this implies that you're kind of positive for SIRS. And this starts to make us worried that there could be sepsis. Now, this is very non-specific, and it's meant to be, because we want to cast a huge net, and bring everybody in who could possibly have sepsis, and then we can eliminate people who don't once we've kind of thought about it, but we don't want to miss people. So this is not specific. If I, ran right now halfway around my yard or something, I'd probably have a high heart rate and a high respiratory rate. That's 2 of 4 of these, but I certainly am not septic, right? Because the other part of this is you have to have an infection. So if someone comes in and they have dysuria or burning when they urinate, some suprapubic pressure or pressure where their bladder is, you get a urinalysis. The urinalysis is positive or concerning for infection, and they have a heart rate that's elevated at 110, and their white blood cell count is elevated at 14, right? These are 2 SIRS criteria plus infection, and this would be a patient that we were worried about sepsis. All right, and when we get worried about sepsis, then we start to wonder, is there severe sepsis, okay, or septic shock? And some of this verbiage is simply just verbiage, and it does change when kind of organizations come together with different guidelines. But severe sepsis is usually when there's some organ damage or indication that the tissues damage. I don't know why I put it in there. Tissues are not getting enough blood flow. And this is things for people who work in medicine, like acute kidney injury, acute liver injury, an elevated lactic acidosis, coagulopathy is another one where your blood is not clotting appropriately. And then septic shock is when this has progressed to hypotension or low blood pressure, okay, or kind of severe organ malperfusion. And if you're septic, you certainly should be making sure a patient is not having severe sepsis or septic shock, right? So hopefully that makes sense for how to diagnose it. You have to cast a wide net, high index of suspicion, and really make sure you're thinking about this in patients who are presenting with some of these nonspecific complaints. Treatment for this is really treating the underlying infection. This is critically important. Time to antibiotics if it's a bacterial infection, which it most often is, right? Antibiotics don't work for viruses, they don't work for fungi, they don't work for parasites. So if you have influenza, if you have the flu, antibiotics will do nothing but harm you. But if you have a bacterial infection causing sepsis, it is really important that we treat the underlying cause as quickly as we can, because time to antibiotics is important. The sooner we start treating that infection, the better that patient is the potential to do. Okay, so this is a matter of either starting broad spectrum antibiotics, or if you already have a source, let's say you have a urinalysis that's already positive, focusing on that genitourinary tract, and antibiotics most effective for that. Then the other thing is related to diagnosis, because part of treatment is identifying and then intervening if a patient has severe sepsis or septic shock, right? That organ damage or kind of that circulatory collapse that can happen. And then the treatment for this does involve, there's, certainly debate always on some of the complexities of this, but involves intravenous fluids, right? IV fluids. It involves kind of monitoring organ function. I'll say monitoring organs. It involves, again, antibiotics, time to antibiotics. And then it involves trying to detect the exact cause of infection, the exact bacteria. With blood cultures, and if it's a pneumonia, x-ray of the chest, if it's an infection in the urine, sending the urine for a culture, et cetera, et cetera. So doing a little more hunting for the cause of infection. So septic shock. Well, if we start just by trying to define loosely what septic shock is, septic shock is a life-threatening, that's fair, subtype of sepsis that requires rapid recognition and treatment. It's characterized by circulatory, cellular, and metabolic abnormalities that can lead to really high mortality. So if we try to decipher this a little bit more, septic shock has two words in it. One is septic, the other is shock. Shock, at its most kind of basal definition, is systemic tissue hypoxia. And this is that your tissues, your organs, are hypoxic. They're not getting enough oxygen. And that leads to tissue damage and organ dysfunction and multi-organ failure. Okay, so that's shock just in general. Then we talk about septic. Well, we've talked about sepsis on this channel before, and we know sepsis is when you get an infection and it leads to a deranged immune response. And that deranged immune response, although it is intended to help you, actually can cause organ injury. So septic shock is where you have sepsis and it causes shock. And yes, it's life-threatening. Yes, it requires rapid recognition and treatment. And yes, it's characterized by circulatory, cellular, and metabolic abnormalities that can lead to a high mortality. So all of that is true. If we think about what exactly it is, well, there is a formal definition, okay? We kind of talked about the informal definition, which was sepsis and shock. Right? So it's when sepsis causes shock. But the formal definition we get from this thing called Sepsis 3, and this is a large kind of formal governmental organization that was birthed by CMS, although it has a lot of buy-in from different specialties as well. So this is somewhat Americanized, but it is applicable in other countries too, and there's certainly kind of international involvement in the definition of all these things. But they essentially define it below. It's when you have sepsis and you're in shock, requiring vasopressors to maintain a MAP goal of greater than 65 millimeters of mercury, and this is despite fluids, and you have a lactate greater than 2 millimoles per liter. So this is the kind of textbook organizational guideline definition of septic shock. So you need to have a MAP a mean arterial pressure of less than 65 millimeters of mercury after fluid. So it can't be that they came in with a MAP of 60, but then you gave them a liter of fluid and their MAP normalized. This has to be a MAP of less than 65 after fluid resuscitation, okay? And you need to require vasopressors to maintain that MAP. So this can't be someone with, quote unquote, chronic hypotension or someone who is not requiring vasopressors. Their definition is MAP of less than 65, requiring vasopressors after fluid resuscitation. And then you have to have some sign of end organ damage, which is why they have this lactate greater than 2 millimoles per liter, because this is a sign of end organ damage, and we'll talk a lot more about that. Okay, so that's the formal definition of what septic shock is. Obviously, the preceding rule here is you also have to have sepsis. You have to have an infection somewhere. So it has to be an infection that is leading to host immune dysregulation that then is leading to hypotension, a MAP of less than 65 after fluid resuscitation, requiring a vasopressor with some end organ damage, that lactate greater than 2. Okay. If we go to more informal definitions, sepsis with shock is profound circulatory and metabolic dysfunction, right, that can lead to that tissue hypoxia, which can lead to hypotension and shock. The mortality of sepsis is really high. Here we quoted 40 to 50%. You'll see things ranging from 20 to 50%. So the mortality of septic shock is very, very high. The reason for that is we honestly don't have great treatments for septic shock itself. We certainly have treatments for sepsis, and we certainly have bundles and things we do to try to address septic shock, but a lot of the dysregulation, which we'll talk about in the pathophysiology, doesn't have this firm treatment that can reverse that immune dysregulation, right? We kind of support the body and treat the underlying cause of the septic shock. And as such, this mortality has remained really, really high over time. The pathophysiology of septic shock, well, as we mentioned, septic shock results from a dysregulated host response to infection. Let's just ponder that for a minute because this is really, really important. So you need to have an infection and you need to have a dysregulated host immune response. That's your body saying, okay, there's an infection. I got to go attack that infection with my immune system. But that immune system activation is dysregulated to a degree where that in and of itself starts injuring cells in the body. Because your immune system has mechanisms to kill bacteria and viruses and parasites and fungi and cancer cells and all sorts of stuff. But those can also injure your own cells. So if you have dysregulation of that host response, that can lead to injury and death of your own cells, which can lead to tissue injury, can lead to release of more metabolites that then can cause vasodilation and some of these other things that we'll talk about in a second. So when you have that dysregulated host response, something starts to happen. And we're going to do an advanced septic shock lecture on the pathophysiology to really dive into this. So definitely subscribe and keep an eye out. It'll be both on the YouTube channel, Patreon page, as well as the podcast. But what essentially happens is you start to get immune cells, and we're going to do a little drawing here. You start to get immune cells, let's just say, we'll draw this here, that have these receptors on them. And there's a whole slew of different receptors. One of the main ones people talk about are TLRs, toll-like receptors. When you have bacteria or viruses or things that are in the body, the toll-like receptor can recognize those. It can activate. There's things like pathogen-associated molecular patterns, PAMPs. There's also a DAMPs. But that activation then leads to this massive release of cytokines. Cytokines are a whole bunch of different molecules that essentially get released throughout the body and augment the inflammatory and immune response. So once there's those cytokines released, it starts to attract different immune cells, but it also can modulate some of our blood vessels, and you start to get vasodilation. So if this is your blood vessel normally, it starts to dilate. Let's just do some symmetry here. It starts to dilate, okay? So this would be the normal size of the blood vessel, more narrow, and then you start to get this release of cytokines, and it causes vasodilation, okay? Vasodilation. That vasodilation can lead to a degree of hypotension because as those blood vessels dilate, you still have the same circulating blood volume in larger dilated blood vessels, and that can lead to decreased blood pressure, hypotension, that MAP less than 65 we talked about. But that's only one piece of the puzzle, because the other thing that these cytokines do, if we were to zoom in on one of the walls of the blood vessel is coated in Endothelial cells. These are the cells that make up the blood vessel wall lining. They have nuclei, just like all cells. Well, we shouldn't say all cells, but most cells. But what can happen is these cytokines, when they attract the inflammatory response, as well as some of the receptors on the endothelial cells, causes some capillary leakage. So these endothelial cells start to create openings within the blood vessel wall that allows fluid and cells and molecules to leak out of the blood vessels into the interstitium. And that's increased capillary permeability or capillary leakage. So you get vasodilation, capillary leakage, hypotension. All that can lead to organ hypoperfusion. Your blood vessels aren't able to get enough blood to the organs to oxygenate them. And that leads to that more kind of pathophysiologic definition of shock, that is tissue hypoxia, or not enough oxygen to the tissues. That organ injury and that tissue hypoxia can lead to that classic lactic acidosis that we talk about, an elevated lactate that so often can come with septic shock, although not always, but most times. And this is a spiral, because as you get more damage to the blood vessels, you get more release of inflammatory mediators, you get more of that vasodilation, capillary leak, and this is an incredibly complex process. There's microthrombi and kind of relative adrenal insufficiency and all sorts of stuff, which we're going to dive into in the more advanced videos on septic shock pathophysiology. But yeah, this general pathophysiology is this spiral that ultimately, at the end of the day, leads to multi-organ failure, multi-organ injury. Right, you can get sepsis-induced cardiomyopathy, which is injury to the heart. You can certainly get acute kidney injuries or AKIs. You can get acute liver injuries or ALI. You can get acute lung injury, another ALI. All of these things can result from septic shock once you start to get that tissue hypoxia. Okay? All right, what is the clinical presentation? Well, the classical clinical presentation is related to what is going on. All right, so the signs and symptoms, you have to have infection first. And signs of infection can be things like fever, also low temperature, hypothermia, things like altered mental status. You can certainly have any signs of infection, burning when you pee, blood in the urine, skin rashes, productive coughs, abdominal pain, vomiting, diarrhea, all of those things that suggest infection. And then you get some signs and symptoms from the end organ injury, the hypotension, or all those pathophysiologic manifestations. And those signs and symptoms include legitimate hypotension. But before you get hypotension, you often get tachycardia, because as your blood pressure drops, what do we know? We know that cardiac output equals heart rate times stroke volume. So as your blood pressure drops, to try to maintain cardiac output, your heart rate goes up. So even before you're hypotensive, you're often tachycardic, okay? And then once your body's unable to compensate, eventually you'll be both tachycardic and hypotensive, but tachycardia usually precedes the hypotension. Now, there is a lot of caveats to that. Someone's on a beta blocker, or calcium channel blocker, some other AV nodal blocking agent, or they have other comorbidities that prevent them from mobilizing tachycardia. And then tachypnea. I always say that when someone is tachypnic without lung pathology, it's a really ominous sign, because it could be suggestive of just overall metabolic demand. Oliguria, or decreased urine output, all these kind of go hand in hand. These are all kind of signs of either compensated or decompensating shock. So signs of infection, as well as signs of blossoming hypotension, blossoming compensated, decompensated shock, all that good stuff. And when to expect it, we will talk about this triad of infection, hypotension, and elevated lactate. That's when it's kind of smacking you in the head, right? If you've waited until you have an infection and hypotension and an elevated lactate to say, hey, look, we got it, we got septic shock, you're way behind the 8 ball. So really try to identify it. We sometimes talk about these things, compensated shock, which sounds like an oxymoron, because how can you be in shock if you're compensated? All right, but for the definition of the term shock, we talked again, tissue hypoxia. And you can have a small amount of tissue hypoxia or impending tissue hypoxia while still normotensive. And this is that compensated shock. Because as we said, as your cardiac output is heart rate times stroke volume. And as you get hypotensive, you try to crank up your cardiac output to maintain tissue perfusion. And to maintain that tissue perfusion and to increase your cardiac output, your heart rate goes up. And as your heart rate goes up, you might still be maintaining organ perfusion at this point. And this is when shock is compensated. All right, maybe you just have a wide pulse pressure, low-grade tachycardia. Maybe you're a little tachypnic. Maybe you're a little confused, a little altered mental status. But at this point, you're still maintaining organ perfusion. Okay, but at some point, this compensatory mechanism is no longer adequate. And that's when you start to get the blossoming end organ injury. And this is when your shock is becoming decompensated. But the best time you can identify septic shock is when it's still compensated, before it's in florid, in your face, infection, hypotension, and lactate. Because if you resuscitate and treat aggressively, that initial kind of compensated shock, people might call it severe sepsis. This is another term on the spectrum of sepsis, right? You start with sepsis, which is just infection. Then you get severe sepsis, which is infection plus organ injury, but without hypotension. And then you have septic shock, which is what we're talking about today. And the severe sepsis category is kind of this compensated shock category. And intervening aggressively there can make a huge difference, because once you get to septic shock, we already talked about that the mortality is really quite high. All right, so if you get to that septic shock phase, you're a little behind the 8 ball, whereas if you can intervene when it's sepsis or severe sepsis and prevent it from progressing, that is when you can really make a big difference. All right, diagnosis. Again, we have the formal diagnosis that people talk about, which is require vasopressors to maintain MAP of greater than 65 despite fluids, and a serum lactate of greater than 2 despite adequate fluid resuscitation. You certainly need a infection as well. So the 3 components for the formal diagnostic criteria are: 1, suspect infection; 2, persistent hypotension. The persistent is important because it has to be after fluids; and the 3, elevated lactate. Now, this is per those sepsis 3 criteria. There's still kind of SEP 1 guidelines that we talk about too. And SEP 1 is just a lactate of greater than 4, independent of whether someone got fluid, or hypotension after fluid. So persistent hypotension defined as a MAP of less than 65 after IV fluids. So there's that formal criteria, and then there's kind of the informal, more pathophysiologic definition, which is those signs of tissue hypoxia plus infection. And this is probably the most important bedside definition in our humble opinion, this tissue hypoxia plus infection, because as we said, there's a lot of different relative scales of compensation that different people can do, whether you're young, old, comorbid, not comorbid, all that kind of stuff. So sometimes we feel if you wait until it's florid, by the book septic shock, it's pretty easy to identify then, and probably behind the 8 ball. So really look for signs of blossoming tissue hypoxia and infection. But for formal criteria, when you're talking about, what's the diagnosis of septic shock, and there's all the kind of criteria guidelines and stuff that you have to abide by to meet compliance standards. This is the formal definitions provided. Step 1, lactate greater than 4, or hypotension after fluid resuscitation. And then the newest SEPS 3, which is suspected infection plus persistent hypotension plus elevated lactate greater than 2. All right, initial management. This initial management is based on, again, this bundle that people talk about. People talk about the 3-hour bundle, the 6-hour bundle. There's a push to have a 1-hour bundle, although this would be incredibly hard to achieve and is not in full force after a lot of the organizations went and said that seems like something that's not going to be very achievable. So we still have 3-hour bundles and 6-hour bundles. All this, though, is these kind of mandated compliance standards. So that's what some of this initial management written here is, which we'll go through. But there's also just some general management concepts that are probably more important to think about. So initial management, the first concept is fluids. As we mentioned, these patients get vasodilation, and these patients get increased capillary permeability. And they probably have been sick and not feeling good and not eating and drinking much. So most of these patients, not all, but most of them are hypovolemic. They're intravascularly depleted. And what the sepsis bundle criteria would be that they should get 30 cc's per kg of intravenous crystalloid. Now, this is probably going to fall out of favor, and probably has fallen out of favor in some places, but this is the standard for compliance that they use, and some patients certainly benefit from this. But other patients need kind of a more dynamic volume assessment. How to do that dynamic volume assessment is part of incredible wide-scale debate. Some people talk about ultrasound, some people talk about fancier ultrasounds like VTIs and Vexus and all that kind of stuff. Some people talk about trending lactates. Some people talk about pulse pressure variation and straight leg raise and fluid responsiveness. And is it fluid tolerance, intolerance, and responsiveness? And is it a linear progression or more of a spectrum? All these are really advanced topics. Things we'll probably cover on the channel in the future. But the start of this is that most of these patients do require intravascular fluid. Compliance bundles would suggest you should give 30 cc's per kg, but we're a fan of more precision medicine with some dynamic assessments. All right, blood cultures. All these patients should get blood cultures. It's important to try to identify what organism is causing this infection, and then they should get IV broad spectrum antibiotics. The keys here are IV intravenous and then broad spectrum. And this doesn't have to be the most broad spectrum, but some degree of broad spectrum antibiotics. If they're hypotensive, we should use vasopressors. The first line vasopressor recommended is norepinephrine, brand name Levophed. This is the first line vasopressor for many, many conditions, including septic shock. So if the MAP is less than 65, low threshold to start norepinephrine. And then you want to monitor things. We still trend lactates. There's certainly some debate there. Monitoring the MAP, monitoring urine output. So really monitoring signs of end organ dysfunction, okay, is the big thing here. So make sure the kidneys are working with good urine output, trend the creatinine, trend the liver function test to make sure they're not developing acute liver injury, trend the oxygenation, make sure they're not developing acute lung injury, watch the cardiac function, whether that's with bedside ultrasound or other modalities, trend the lactic acid. Don't put all your eggs in any one of those baskets and be reactionary, but all of them together can kind of paint a little picture about general organ perfusion. Additional consideration, source control can be very important. So you always want to make sure that there's source control. If someone has an abscess, it needs to be drained. If someone has an obstructing stone, obstructed nephrolithiasis with hydronephrosis, they need to have drainage of that, whether it's a ureteral stent or percutaneous nephrostomy tube. If someone has cholangitis, they need decompression of their biliary tree. If someone has necrotizing fasciitis, they need debridement of that infected fascial plane. Sorry about that. So source control is important. When patients are not getting better, sometimes it's because they have a source that has not been identified. So that's something to think about that you might have to come back to. Steroids, if shock is refractory. There is some debate, although I think most people would agree that stress dose steroids are indicated, although when to start those steroids, which steroids to choose, is it hydrocortisone or hydrocortisone plus fludrocortisone or something different? Lots of debate there, but if someone has persistent vasopressor dependent septic shock, most people would agree that steroids are probably indicated, but again, some debate in the literature. And then monitor glucose is you want good glycemic control, and then in addition to that, early nutrition can be important too, assuming perfusion markers are improving, that their vasopressor requirements are going down, maybe their lactates going down, and consider early enteral nutrition. Prognosis and outcomes, unfortunately, and mortality, as we said, is somewhere between 20 and 50%. Early recognition and management does reduce the risk of mortality. How much is unclear, but we've hit a little bit of a plateau. We probably need some more aggressive research into other ways we can help treat these patients. But identifying early and treating aggressively early is absolutely critical in trying to blunt some of that downstream morbidity and mortality. We do have a little visual summary here. If you're listening to the podcast, we'll read some of it. If you're watching the video, we do have a little summary slide here. And that is septic shock definition. To review, sepsis with vasopressors needed to maintain a MAP of greater than 65 and a lactate of greater than 2 despite adequate fluid resuscitation with signs or suspicion of infection. So pathophysiology, infection leads to immune dysregulation, which leads to vasodilation, capillary permeability, hypotension, poor tissue perfusion, lactic acidosis, and end organ injury. Clinical presentation, we often see whatever is causing the infection, as well as altered mental status, tachypnea, tachycardia, fever, hypothermia, hypotension, elevated lactate. You certainly don't often have all of these things. You might have just a few of them, and that is much more typical. And management concepts are intravenous fluids, whether that's 30 cc's per kg, as some of the guidelines would suggest, or whether that's a more dynamic volume approach, some to be debated. Broad spectrum antibiotics early, get blood cultures, and support patients with vasopressors for MAPs of less than 65. Norepinephrine, we spelled it wrong. Clinical pearls, something that comes up sometimes I hear people say, which is kind of catchy and true, but time equals tissue. Like people say time equals brain with stroke and time equals myocardium. It's not necessarily different for sepsis, right? Now, some of those organs bounce back better than something like a brain or a heart does. Your kidneys and liver might bounce back a little better, but time does equal tissues. The longer those tissues and organs have hypoperfusion from septic shock, the more damage they're going to have, and the more kind of chronic damage they may have. So treat early, treat aggressively, and have a low clinical index of suspicion so that you diagnose this early enough. Clinical pearls here, lactated ringers is often preferred over normal saline. This is highly debated. We personally often use lactated ringers, although there is evidence to suggest that it might not matter. There's evidence to suggest that lactated ringers are better, so highly debated. And then reassess frequently. This is really important. These patients are not resuscitate them once and forget about them. These are patients that need frequent reassessments to make sure you're doing everything you can to get source control, treat the underlying infection, and support the organs with vasopressors, fluids, and what have you. So not set and forget it. Definitely dynamic reassessments.
Particularly the pathophysiology of septic shock. This is still going to be somewhat of a basic introductory discussion, but a little bit of a deeper dive than some of the other sepsis videos we've done. Whether you're listening to this in podcast form, watching it in video form, we will link in the description to this episode some additional information and previous videos and podcasts on sepsis and septic shock, so definitely check those out. All right, so septic shock pathophysiology. Today we're going to be particularly diving into 7 different parts of septic shock pathophysiology. We're going to start with immune activation. We're going to then dive into the cytokine storm, talk about endothelial dysfunction, coagulation cascade, mitochondrial dysfunction, adrenal insufficiency, and multi-organ dysfunction. So kind of a jam-packed agenda. We're going to tickle the surface of each one. To start, we just got to help understand some of kind of the basic foundational definitions of sepsis and septic shock. And the thing to remember here is that septic shock actually results from a dysregulated immune response to infection. All right, that's a foundational principle here. So what does this mean? Well, what we have in this definition is dysregulated immune response and then to infection. So obviously the foundational principle here is you have to have an infection. All right, this is often a bacterial infection, pneumonia, cystitis, bacteremia, bacteria in your blood, endocarditis or infection of the heart valves, intra-abdominal infections such as appendicitis, cholecystitis, but there is such thing as viral sepsis. Not as common in our day-to-day practice, but there is fungal sepsis as well. Any infectious organism, but that's a foundational principle. You need an infection. Then what happens, though, is your body has this dysregulated immune response to that infection. Right? Your body's full of immune cells, and those immune cells are needed to keep you alive because those immune cells attack invaders. So when a bacteria, say, gets into your body and causes infection, let's just say that infection is pneumonia or infection of the lung. You got 2 little lungs here. Your immune system says, wait a second, there's a bacteria invading our body. We got to mobilize a response. And this causes lots of downstream things to occur because bacteria, just like cells, are living, right? So the things that can attack and kill bacteria also can sometimes injure cells, and they do certainly cause changes to the body. And these changes to the body, if they spiral out of control, can cause shock. All right, and shock in its simplest definition, we've certainly talked about shock on this channel multiple times before, so just search WhiteBoard Medicine shock and a bunch of stuff will pop up, or if you're watching this in YouTube form, we have a bunch of playlists on our channel and our critical care medicine playlist. There's certainly several videos on shock, but shock at its simplest level is this systemic tissue hypoxia. What does that mean? That means that the tissues are not getting enough oxygen delivered to them, aka hypoxia. That does not necessarily mean that the oxygen levels are low. That would be hypoxemia. But hypoxia just means there's not enough oxygen being delivered to the tissues as compared to how much oxygen those tissues are demanding. Okay? And that causes shock. That causes tissue injury. So septic shock, sepsis is infection, shock is systemic tissue hypoxia. So you have an infection, it causes this dysregulated immune response that then can lead to shock. But let's break that down farther. Let's start with immune activation. So when we think about immune activation, as we said, you have an invading infection, and that causes these things called PAMPs and DAMPs. PAMPs are pathogen-activated molecular patterns, and these are on cells. So if we look to this diagram, and we'll vocalize this out loud for those just listening in podcast form, but your immune cells have receptors on them. And those receptors can be PAMPs or DAMPs, and they're just essentially there to recognize different patterns of membranes of invading organisms. Again, let's go with bacteria. So bacteria have a cell surface. Okay, so here's a bacteria. On that cell surface, there's all these proteins and glycoproteins and lipopolysaccharides and different things. And your immune system's smart. It gets smarter and smarter over time because your immune system starts to have these pattern recognizing receptors on the surface of immune cells that say, hey, I recognize that, glycoprotein, that is from a bacteria. Let me activate my immune response, usually through things called toll-like receptors, okay? And what that triggers or can trigger in the setting of septic shock is this release of inflammatory cytokines. Cytokine's a buzzword. If people followed COVID closely, cytokine storm was something that was thrown around often. But cytokines are these signaling molecules like TNF-alpha, also known as tumor necrosis factor alpha, ILs, which stand for interleukin, interleukin 1, interleukin 6. There's tons more. Okay, there's tons more. But these cytokines are released into the blood or the surrounding environment, and they cause this signaling cascade to occur. And depending on the exact cytokine will drive what signal is starting to cascade. But all of these cytokines getting released then cause a lot of downstream effects, and that's what we're going to talk about a little bit more. When it comes to septic shock, that dysregulated response, there's something about the cytokine release that is more robust. Okay, and that more robust cytokine release causes a more robust immune reaction to that infection. And it can cause things like cytokine storm. Cytokine storm, this is somewhat of an informal definition, right? We like to cross out storm, even though people classically talk about it. But cytokine release can cause systemic vasodilation and increased capillary permeability. Okay, that leads to decreased systemic vascular resistance, which can lead to hypotension. Let's break that down further. So it causes systemic vasodilation. So if this is a blood vessel here, some of these cytokines interact with different cells, smooth muscle cells, endothelial cells that line the blood vessel. Blood vessels are kind of wrapped by smooth muscle. And these cytokine signaling molecules can cause that blood vessel to dilate, okay, increase in size. The other thing it can cause, and we're going to talk about it more below, so we're just going to mention this out loud, but it can cause increased capillary permeability. Where these capillaries, so you have big arteries go into smaller arterioles, which then goes into this capillary that then dumps into what we call venules, veins, okay? And this capillary is kind of where exchange happens with the tissues, okay? Red blood cells deliver oxygen to the tissues, carbon dioxide is reabsorbed in the capillaries because you go from arteries into capillaries into veins, and the veins go back to the heart and to the lungs, and that blood circulates around again. But this capillary level is where a lot of the exchange of nutrients from the blood into the tissues, as well as from the tissues into the blood, occurs. The other thing that happens at those capillaries is cells. Cells from inside the capillaries go out into the tissues, like immune cells, and cells from outside the capillaries can go back into the blood vessels. This can happen in the lymphatic system too, but kind of outside the purview of this discussion. But when you get this activation of the immune system, when you get the release of cytokines. So cytokines can cause the systemic vasodilation or dilation of these blood vessels. And those blood vessels, when they dilate, it drops vascular resistance, which makes sense. The resistance of the vascular space is related to several things, but one of those is blood vessel diameter. So as the diameter increases, there's less resistance, and that can lead to hypotension. If you just picture, if we just make up an analogy, you have a big pipe. That pipe's full of fluid. If you were to increase the diameter of that pipe, dilate the diameter of that pipe, the amount of fluid would still stay the same, but those pipes would be more empty because they dilated. So that can cause hypotension, okay? We mentioned capillary permeability because the other thing that can happen is endothelial dysfunction. What does that mean? Endothelium are the cells that line the blood vessels. So there's a diagram here, we'll speak it out loud, but this is a capillary, okay? And that capillary is lined by endothelial cells. That's what makes up the walls of the capillary. But when you get this cytokine release, there's endothelial injury that happens, and that causes leakage of plasma into the interstitial space, right? So if you look here, capillaries usually have all these tight junctions between endothelial cells, so it's very regulated what can go out of the capillaries and also what can be reabsorbed back into the capillaries. When you start to get endothelial injury and damage, you start to break down that barrier, so things can leak out of the capillaries into the tissues. Okay, and a lot of that might be plasma. So you might lose some of your intravascular volume from capillary leak. It can lead to hypovolemia, okay, or decreased intravascular volume because it's leaking out. All right, what else can happen? Well, there is this interesting coagulation cascade. So when your blood is flowing through the blood vessels and you get a cut and that blood vessel gets injured, there's a coagulation cascade that occurs with all these coagulation factors. There's tons of coagulation factors. There's vitamin K dependent ones like 2, 7, 9, 10. Okay, there's tons more. There's 5, there's 8. You can keep going through all this, but these all, as well as fibrinogen, as well as platelets, contribute to blood clotting. And when you have injury to those blood vessels, this coagulation cascade is activated and leads to a blood clot, right? That's why you just don't bleed out all the time, because your blood will clot when that endothelium, when that blood vessel wall is injured. Well, the same thing can happen in septic shock because those cytokines in that immune reaction is damaging those endothelial cells of the blood vessels. So that can activate this coagulation cascade, and it can lead to microthrombi developing, small blood clots in the capillaries themselves. And this can lead to some degree of organ ischemia. There's also this additional entity called DIC, or disseminated intravascular coagulopathy. I don't know why we decided we were going to write that out in real time, but intravascular coagulopathy that can occur. And this doesn't occur in everyone, but sepsis is a risk factor among another number of other things. But yeah, you can get these microthrombi that form in your small blood vessels, which can lead to additional organ injury. The other thing we can see happen is some mitochondrial dysfunction. So as your tissues start to get less blood flow, you have all these inflammatory cytokines circulating around. It can lead to impaired ability to utilize oxygen in the cells. And your mitochondria, everyone, this is a mitochondria. Everyone remembers the old adage, mitochondria is the powerhouse of the cell. So the mitochondria don't have enough oxygen to do aerobic metabolism, which is the most efficient way to produce energy, ATP. So what they do is they go into anaerobic metabolism, which is a whole different pathway. And part of anaerobic metabolism leads to the excretion of lactic acid. And for those of you who work in the clinical arena, you'll know that for a lot of our sepsis patients, we send lactate. It's a test that we do. And although there's lots of things that can cause lactate to be elevated, one of those is tissue hypoperfusion or tissue ischemia or tissue hypoxia. So it's a surrogate marker, and it's not perfectly correlated, but when lactate is high, it can imply that we are in more of a state of anaerobic metabolism, which can imply that our tissues are not getting enough oxygen delivery, or that, our quote-unquote septic shock is quote-unquote bad. Again, lots of caveats to that, but that is one of the things that can occur, and it's because we don't have enough oxygen being delivered to those tissues. There's also some evidence potentially that there's some mitochondrial injury just from the inflammatory response in general, although there's a lot of kind of discussion around that. All right, what else? Well, there's some literature to suggest that you get this relative adrenal insufficiency. Okay, adrenal insufficiency is your adrenal glands produce hormones, particularly cortisol or steroid. And when you have something going on in your body, you get increased levels of cortisol because that assists in a lot of downstream effects to try to maintain homeostasis, to try to maintain organ perfusion and all those other things. But if you have some adrenal insufficiency or some suppression of your adrenal gland's ability to produce cortisol and other hormones, that can lead to worsening shock. Some people talk about vasopressor resistance, where your vasopressors don't seem to be working. Now, why this happens and if it happens in everyone is very unclear. It doesn't seem like it happens in everyone, but who it affects and who it doesn't is really difficult to tease out. But one thing that you'll see and that we do is some patients we give stress dose steroids to. And there is a fair amount of evidence for this, although there's mixed literature, and there's certainly people that don't believe in the literature around it, and that's okay. But I think most people would suggest that stress dose steroids are indicated in patients with vasopressor resistant shock or fluid resistant shock. Probably a whole separate lecture we can do on stress dose steroids and septic shock, and we'll really dive into the evidence. But the rationale is that you can get this relative adrenal insufficiency from suppression of your adrenal glands, or this HPA axis. All right, hypothalamus pituitary adrenal gland, HPA. All right, and all these things can culminate in multi-organ dysfunction, and in its worst form, failure. And this is the dreaded complication of septic shock, is your organs literally start to fail because they have so much injury. Your heart can get damaged, both from having to work in kind of hyperdrive to pump blood around the body, as well as direct damage from those cytokines. There's this thing called sepsis-induced cardiomyopathy. We're going to be talking about this in a future sepsis episode. Your lungs, you can get acute lung injury. You can get ARDS. We have a whole series out on ARDS, which is acute respiratory distress syndrome. Many patients get acute kidney injury, thought to be from low perfusion of the kidneys, aka you can't get enough oxygen pumped to the kidneys, as well as microthrombi is thought to play a role. In the liver, you can get acute liver injury as well, some cholestasis, which is where your bile from your gallbladder gets a little thick and doesn't get pumped out as effectively, and you actually have a risk for something called acalculous cholecystitis. All right. And then your brain, a lot of these patients can get delirium and encephalopathy. Why that happens is really tough to tease out. It's an active area of research, but some think it's from kind of this larger inflammatory response that affects the brain, just like it affects other organs, as well as, some of this hypoperfusion, possibly microthrombi, all that kind of stuff. And when this ends up progressing and you get multi-organ failure, this really increases the mortality. The mortality of septic shock, as we've talked about in previous episodes, is really high. It depends, but somewhere around 20 to 50%. And this multi-organ failure is often the culmination of all these other things that can occur. So septic shock pathophysiology is really multifactorial. It's a combination of things. It's a combination of that kind of dysregulated immune response that then can lead to vasodilation, or the dilation of those blood vessels, which can lead to hypotension, increased capillary permeability, which then leads to some fluid leaking out into the tissues that then can cause some hypovolemia. Microthrombi can occur, direct microvascular injury. You can get adrenal suppression that can lead to not enough cortisol being released. Okay. And all this can kind of culminate in multi-organ injury or failure. So hopefully that was an okay kind of forest from the trees, high-level overview of the pathophysiology of septic shock. This is a very complex condition. This is something that there's tons of active research going on, and we certainly don't have a perfect understanding of it. We also don't have a perfect understanding of what to do with some of the knowledge that we have in terms of intervention. In today's episode, we will be talking about sepsis-induced cardiomyopathy, another episode in our sepsis series. We will be coming out with a whole bunch of additional sepsis videos, but what have we done so far? Let's see, we've done sepsis basics, septic shock basics, deeper dive into sepsis pathophysiology, sepsis phenotypes. We're now doing sepsis-induced cardiomyopathy and more to come. If you're listening on our podcast or watching this in YouTube form, just know that you can find either the video or the podcast version linked. We also will upload the study guide to our Patreon page, which will be linked in the video description as well, or the podcast description. And then we also have a weekly newsletter that is totally free, that the sign up will be in the description too. So enough of our little hype story there. With no further ado, sepsis-induced cardiomyopathy. So sepsis is one of the leading causes of morbidity and mortality in critical care. We've talked about this before, right? The mortality is variable, but somewhere between 20 and 50% for septic shock, right? These really, really sick patients. And we've improved that a little bit, but not nearly as much as I think we all would have hoped over the last couple decades. Something we're starting to realize, though, as time goes on, is that something can happen to the heart itself from this dysregulated immune response. Because those who haven't seen our previous sepsis videos, we've talked that septic shock is really driven by this dysregulated host response to infection. Your immune system that obviously is there to fight infection, we certainly need it, goes into overdrive a little bit, and it has this kind of hugely robust and somewhat dysregulated response that then can lead to, as we talked about in the pathophysiology video, massive cytokine release, vasodilation, capillary permeability, endothelial injury, microthrombi, relative adrenal suppression, some possible mitochondrial dysfunction too, multi-organ injury and all that kind of stuff. So this dysregulated immune response, just like it affects the kidneys and causes acute kidney injury, and it can cause acute liver injury, it can cause acute lung injury, it can cause kind of quote-unquote brain injury with things like delirium encephalopathy. It certainly affects the heart too. And that's kind of cueing in the topic for today, which is the sepsis-induced cardiomyopathy. Particularly, we'll talk about the epidemiology, the mechanisms, diagnosis, why it matters, prognosis, all that kind of stuff. So no further ado, starting with epidemiology. So sepsis-induced cardiomyopathy, also known as septic cardiomyopathy, can occur in actually 30 to 50% of patients with septic shock. That's the key, is septic shock. This isn't just severe sepsis or sepsis. Again, phrases we've talked about in previous videos. But 30 to 50% of those in septic shock. Now, there is a lot of variability, and this is really important because there's several different kind of definitions or diagnostic criteria for sepsis-induced cardiomyopathy, and depending on which one of those definitions you use, drives a little bit of the variability with how often this occurs, right? Because if your definition is very loose, this is going to occur more often in folks. If your definition is very stringent, it's going to occur less often. But that does not mean the disease is not there. It just means the way we are defining it is slightly different, which then drives some of that variability. The good news is, when it comes to sepsis-induced cardiomyopathy, is it is reversible in most cases. You get myocardial dysfunction, right? Myocardium being the muscle cells of the heart, and that does tend to recover once the septic shock is improving, which we'll talk more about too. It doesn't seem that there's a predilection to a different gender. It doesn't seem like it affects males or women, males or females more or less. But older adults, no surprise, do seem to have worse outcomes, as well as anyone with underlying cardiac disease. Both these things make sense, right? If you're older and more comorbid, you probably are not going to fare as well when you get damage to your heart. If you have underlying heart disease already, you're probably not going to fare as well to get kind of the second hit from septic shock. All right. It is also associated, we do know, with increased ICU length of stay, increased need for vasopressor support, mechanical ventilation, and often correlates with higher SOFA scores and Apache 2 scores. And these are two kind of risk stratification scores that help us understand the severity of the septic shock. There's been some correlation with things like morbidity, mortality, and all that kind of stuff. So the summary here, which is no surprise, is that sepsis-induced cardiomyopathy seems to cause patients to be quote-unquote sicker. Now, the counterpoint to that would be, does it cause patients to be quote-unquote sicker, or do sicker patients more often get sepsis-induced cardiomyopathy? And we'll have more discussion on that as we go through the video, although there may not be a definitive answer, at least not yet. So pathophysiology, how and why does this happen? Well, we know that sepsis-induced cardiomyopathy is myocardial depression. As most of us probably know, the heart, we're going to draw a heart on the screen if you're watching. This is the right atrium, right ventricle, left atrium, left ventricle. We know that the myocardial muscle cells of the heart, just like many cells, are affected by some of the dysregulated immune response in septic shock. Those inflammatory markers like cytokines, metabolic derangements, and autonomic pathways too. The heart is innervated in many senses by our autonomic pathways, things like the vagus nerve and sympathetic stimulators and all that kind of stuff. So these types of things all affect myocardial cell health. And this complex interplay is what can lead to myocardial cells, again, being the muscle cells of the heart, depression, which is thought to lead to sepsis-induced cardiomyopathy. Now, we use a lot of kind of big, what we consider generic statements, so we're going to dive a little bit deeper. Some of the key mechanisms. So the first is inflammatory cytokines. As we talked about in our septic shock pathophysiology lecture, this dysregulated immune response that happens in septic shock, part of that is a huge release of inflammatory cytokines. Things like TNF-alpha, tumor necrosis factor alpha, a bunch of different interleukins, IL, interleukins, 1-beta, interleukin-6. There's a bunch more. But these are thought to directly suppress and affect myocardial cell contractility. And the contractility of myocardial cells, these are the muscle cells of the heart, and how well they're contracting does contribute significantly to how well that heart is pumping blood, that heart ejection fraction. The thought is that there's this nitric oxide-mediated pathway involved. We're not going to dive too deep into this. Lots of stuff out there on this, but the thought process here is that the nitric oxide leads to CGMP upregulation, which then can affect calcium influx into myocytes. Calcium, we joke that calcium is kind of nature's vasopressor inotrope, and that with decreased calcium influx, these myocytes can't contract as robustly, which then blunts inotropy. If this word is foreign to people, this is essentially kind of the quote-unquote contractility of the heart. All right. Another pathway involved is probably mitochondrial dysfunction. Mitochondria is the powerhouse of the cell. It produces energy in the form of ATP. And we know that sepsis, we talked about this again in our pathophysiology lecture, that there's some mitochondrial depression in sepsis. And part of this is from lack of oxygen, adequate oxygen delivery. But part of this might be direct cytokine effects on mitochondrial function. But sepsis impairs the mitochondria's ability to do oxidative phosphorylation. Thus, the mitochondria cannot produce enough ATP, and that leads to the myocardial cells not having enough oxygen to kind of function at their peak. And that can lead to decreased cardiac function. Another key mechanism here is autonomic dysregulation. So we've talked about inflammatory cytokines, mitochondrial dysfunction, now autonomic dysregulation. As we mentioned, the heart has innervation, nerves that affect its function, both sympathetic, being stimulatory, and parasympathetic, being blunting. And these are often driven by beta-adrenergic receptor signaling pathways and stress responses from things like cortisol. And what we know is that in septic shock, some of these pathways have dysregulation, just like our immune response is dysregulated. And the dysregulation in some of these sympathetic and parasympathetic pathways can lead to abnormal beta-adrenergic signaling of the heart, and that can then lead to myocardial, decreased myocardial function, or a dysregulated myocardial function. In addition to that, there's some evidence that in certain patients with septic shock, there's kind of relative adrenal insufficiency, meaning there's not enough cortisol being produced, and certainly that can contribute as well to myocardial dysfunction. Microvascular dysfunction, kind of the microcirculation, is a big thing in septic shock, and shock in general, but particularly in septic shock. And what we know is that the endothelial cells that line the capillaries get affected by this inflammatory response, cytokines, immune cells, and it can cause endothelial activation and cause endothelial damage with capillary leak. And the coronary arteries and veins that provide oxygen to the heart, just like the blood vessels that provide oxygen, blood flow to the other organs, are affected. And that can lead to myocardial cell edema, or kind of more fluid in those myocardial fibers. It can lead to a mismatch with oxygen supply and demand, so the myocardial cells are not getting enough oxygen delivered compared to how much demand there is for oxygen. And that can then lead to myocardial injury or death. And this mismatch between oxygen supply demand, as well as some of the microvascular damage done by septic shock, can all lead to worsening cardiac function. And then last is this direct cardiomyocyte injury. So toll-like receptor activation of some of these myocardial cells. Toll-like receptors are these receptors on cells that are activated by kind of quote-unquote foreign invaders, foreign proteins, glycoproteins, lipopolysaccharides. All these can activate toll-like receptors on cells. The cells are essentially detecting that there's an invader in their midst, and these can lead to direct cardiomyocyte. All right, so myocardial cell injury, including apoptosis, where that cell actually commits suicide, it kills itself, and necrosis, right, that those cells are dying. So these are the 5 key mechanisms thought to be involved. If you go on a deep dive, there's certainly a ton of other stuff, and these aren't even that well teased out either. Some of these are debated upon, but it does provide a nice framework, being inflammatory cytokines, myocardial dysfunction, autonomic dysregulation, microvascular dysfunction, and then direct cardiomyocyte injury. The nice thing here is that, unlike ischemic cardiomyopathy, which is where your coronary arteries are actually plugged, they got thrombotic disease that leads to myocardial ischemia. Sepsis-induced cardiomyopathy is not due to coronary artery occlusion. Okay, there's not a coronary artery that you got to go and stent that then fixes sepsis-induced cardiomyopathy like it could for ischemic cardiomyopathy. Right? This is a functional myocardial suppression secondary to the systemic illness being septic shock. Okay, so keep that in mind as we kind of think about the pathophysiology and the interventions that might be helpful. This is very, very different from ischemic cardiomyopathy, where you actually have a thrombosed coronary artery. This is a global functional disease. So how do we diagnose it then? We kind of talked about how it happens. We talked about how often it happens, who it affects the most. How do we diagnose it? Well, there are some clinical clues, although this is really difficult, okay? Some of the clinical clues are hypotension refractory to fluids requiring vasopressors. In our humble opinion, this is not that useful. This could just be severe, septic shock with microcirculatory dysfunction. Many patients in septic shock have hypotension refractory to fluids. That's kind of part of the definition of septic shock. So we don't believe that this is that helpful, but people do talk about it. Signs of low cardiac output is helpful, okay? So if you have adequate preload, which means the heart is getting enough kind of filling from the blood volume, so the patient is appropriately resuscitated with fluids, and despite this, they still have low cardiac output. This is a fairly good indicator that there could be sepsis-induced cardiomyopathy. Okay, and then discrepancy between vasodilation and cardiac performance. It seems like the heart is not functioning as it should compared to the degree of kind of vascular vasodilation going on. Can also imply sepsis-induced cardiomyopathy. But really you need imaging to diagnose this. And the biggest type of imaging here is transthoracic echocardiogram, or TTE. And what it will show is some global hypokinesis of the left ventricle. That left ventricle is not contracting robustly enough. But it's not just one part of the left ventricle, right? It's not that just the interior wall is down. This is global dysfunction of the left ventricle that then leads to reduced LVEF, left ventricular ejection fraction, often less than 50%, but it can go much lower, okay? But often less than 50%. The LV dilation is most likely present, which is a compensatory feature. And then a lot of these patients have a right ventricular dysfunction as well. This can be prognostically relevant, right? You have two sides of your heart, as we know. You have a right ventricle and a left ventricle. The left ventricle is often what we think about. We think about sepsis-induced cardiomyopathy, but if the right ventricle is involved too, this is biventricular failure, BIV failure, both ventricles. And this has a worse prognosis than if it was just the left ventricle. This can be really, really, really difficult to manage. You can send biomarkers like troponin and BNP. In our humble opinion, these are really non-specific. They're probably going to be elevated, but what to do with them is very unclear, right? Troponin is probably going to be elevated because that patient is in septic shock, so their heart's working in overtime, and that leads to some degree of myocardial cell injury, which then releases some troponin, but not probably very relevant. BNP, brain natriuretic peptide, is probably going to be elevated, but this can be elevated in sepsis in general, and again is very non-specific. So we are not a big fan of biomarkers playing a huge role in the diagnostic pathway. And then hemodynamics, if you're spoiled enough to have something like a pulmonary artery catheter, also known as a Swan Gans, you can do invasive hemodynamics. We've talked about pulmonary artery catheters on the channel before too. You can search WhiteBoard Medicine. What do we put it under? Maybe pulmonary artery catheter, maybe cardiac chamber pressure, something like that. And we'll put out a more specific video too if people are interested on kind of Swan-Ganz in particular. But it would show a low cardiac index, right? That would tell us the heart is not pumping out enough blood. It often has a high mixed venous oxygen saturation, and then a normal to low wedge pressure. These are really advanced topics. These might not make sense to many people out there, and if they don't, let us know in the comments, because we could put a video out specifically on these different measurement devices, if that would be helpful. But for the sake of this lecture, probably not worth us doing a deep dive in each one of these things, because they could be their own hour-long lecture in and of themselves. So the summary here for diagnostics is, in our humble opinion, really echocardiogram. In the setting of the context, the patient has to have septic shock and has to have a clinical picture that fits sepsis-induced cardiomyopathy, and then you get an echocardiogram, and it looks like their LV, left ventricular ejection fraction, is down. That's pretty consistent with sepsis-induced cardiomyopathy. All right, you do need to exclude acute coronary syndromes. These are those thrombotic coronary occlusions and pre-existing cardiomyopathy. This is probably self-explanatory, but is worthwhile saying out loud. All right, management of these patients. So unfortunately, there's no specific treatment for sepsis-induced cardiomyopathy beyond supportive care and treating the underlying cause being sepsis. Okay, there's no magic, IV medication you could push that then causes myocardial cell recovery. So the core principles related to that are: you want source control, incredibly important. Early antibiotics, incredibly important. These two things make a huge difference. Make sure they don't have an abscess somewhere that needs to be drained. Make sure they don't have cholecystitis or appendicitis, which is not, or obstructive nephrolithiasis with hydronephrosis, right? These are things that won't get better without removing the source or decompressing the source. So early antibiotics and source control. Hemodynamic support, norepinephrine is still kind of our first line vasopressor, even in sepsis-induced cardiomyopathy. Now, if someone has a really low cardiac index, or there's concern that the heart's inability to have optimal contractility and ejection fraction is leading to hypoperfusion, there is some argument to try inotropic support. Mixed literature on this. Certainly no definitive studies out there that support this, but every patient's different and has not been studied in a robust way, so it wouldn't be unreasonable. And then vasopressin is a nice adjunct here. Especially if this is kind of vasoplegia dominant. Oh, it didn't like how we spelled vasoplegia, and we did not ignore that. Apologies. Fluids. After adequate fluid resuscitation, you don't want to keep giving these patients tons of fluids. That will cause congestion, and that will cause greater hypoperfusion. So just throwing additional fluids at these patients can be really detrimental, so be very, very careful. And then this is not something commonly done, but these patients can, in select cases, be candidates for mechanical circulatory support, MCS. Again, we've talked on this channel about ECMO, we've talked about intra-aortic balloon pumps, and all that kind of stuff. Data is limited on the efficacy of these things, not commonly done, but they are done sometimes, and there's probably a future where they're used more commonly. So mechanical circulatory support is the end stage of support that you can provide these patients if your institution has them and does agree to, cannulate and put these patients on pumps. Steroids are possibly helpful. Now, their role in sepsis-induced cardiomyopathy in general is a bit unclear. There definitely are guidelines that suggest steroids, stress dose steroids for vasopressor refractory shock or fluid refractory shock, and we'll put out a separate video on that. So stress dose steroids should be in the back of your mind. And then beta blockers is something people talk about. This is very controversial. Our humble opinion is that the evidence to date does not support using beta blockers to control the heart rate in patients with sepsis-induced cardiomyopathy, but you will hear things out there and read studies on it. And of course, this is not medical advice, but that is our humble opinion. All right, what's the prognosis? You've done everything you possibly can to manage these patients. Well, the hallmark of sepsis-induced cardiomyopathy is its reversibility. All your hard work, all your supportive care in treating the underlying septic shock, most patients will recover normal cardiac function within 7 to 10 days. So a lot of times they need an interval echocardiogram, an interval TTE, to prove that their LV ejection fraction has in fact recovered, okay? Now, sepsis-induced cardiomyopathy does increase short-term mortality. We know that from studies, particularly if there's biventricular failure, right? That there's left ventricular dysfunction and a right ventricular dysfunction. So we know that this increases mortality when you do have it, but we also know if you can bridge someone through that kind of first week or two, that this should recover as the septic shock improves. Longer-term studies suggest that patients who survive sepsis-induced cardiomyopathy don't necessarily develop chronic heart failure. There's certainly more to this, right? There's remodeling that occurs to the heart when you have sepsis-induced cardiomyopathy that may increase your risk for chronic heart failure down the road, but it's not well teased out. It's not well known. And then, as we mentioned in management, early recognition and aggressive supportive care for these patients is absolutely critical. So, in conclusion, sepsis-induced cardiomyopathy, it's common, it's reversible, but it is clinically significant, and it does increase mortality, and it is incredibly hard to manage. It reflects kind of the systemic toxicity to the myocardium. This is not thrombotic ischemia. This is not coronary occlusion. This is kind of systemic global hypoperfusion and direct injury to those myocardial cells. And then echocardiogram is your best tool. Use echocardiogram, support the heart, treat the infection, reassess often. These are all crucial concepts. Today we're going to be talking about sepsis again. Yes, part of our sepsis series. What have we done so far? Sepsis basics, septic shock basics, septic shock pathophysiology, sepsis-induced cardiomyopathy. And today we're going to be talking about one of our nerdy pleasures, which is sepsis phenotypes. This is a more advanced, episode, although certainly lots of things that are just interesting for anybody who has a curiosity about sepsis, and then maybe has some more clinical applicability for those of us that work in healthcare. For those of you listening to this as a podcast, we will link the YouTube video in the description. For those of you watching the YouTube video, we'll link the podcast in the description. We also have a Patreon page that will upload the study guide as well as practice questions, and then a free weekly newsletter. Again, all that linked below if anyone has an interest in those things. No further ado, sepsis phenotypes. Why phenotype sepsis? Well, sepsis in general, as we've talked about, it's more of an umbrella term for a syndrome, okay? People get an infection, and that infection leads to a dysregulated host immune response. And that dysregulated immune response causes a number of downstream things, right? Cytokine release, endothelial injury, microvascular thrombi, adrenal suppression, mitochondrial dysfunction, vasodilation, possibly sepsis-induced cardiomyopathy, but all patients act a little bit different, right? Not every patient with sepsis looks the same. And what we're starting to learn as we start to understand sepsis and really medicine in general is that precision medicine is really important because patients react different from one another. Not everyone is going to react the same if you were to give them a similar kind of clinical problem. Not everybody with pneumonia has this exact similar course, right? Some are totally fine, and then some are critically ill, and some pass away. So that's why we phenotype sepsis, because it seems like there are probably different quote-unquote subtypes of sepsis that affect people. All right, so sepsis is a heterogeneous syndrome with diverse presentations and outcomes. Clinical trials on sepsis have often failed to find a benefit. And one of the theories, although we don't know for sure, but one of the theories is that we're kind of lumping all patients with sepsis together, and then we're doing this intervention. And those patients with sepsis, again, are probably all slightly different, so that intervention doesn't show a benefit. But would it have shown a benefit if we only chose a specific subtype, a specific phenotype phenotype of sepsis and tested that intervention just to that sepsis phenotype? We don't know the answer to that question, but the curiosity is, well, maybe it would have. So when we try to phenotype sepsis, the goal is to improve risk stratification, guide therapy, and enable precision medicine. The easiest thing to compare this to in your mind is cancer, right? It's not just lung cancer. There's multiple different types of lung cancer, right? Maybe it is small cell lung cancer, but it's not just small cell lung cancer. It is small cell lung cancer with this genetic profile. And if we were to test these treatments for this very specific genetic profile of small cell lung cancer for all patients with any generic lung cancer, that intervention may not show benefit, but it does have a benefit against this subtype of lung cancer. Okay, and sepsis might be similar to that. So this is a very new, we shouldn't say that, this is new-ish. There's lots of additional study on it currently. People have been looking at this for quite some time, but it's come under the spotlight a little bit more, sepsis phenotyping, particularly guided by how much we're starting to realize that cancer phenotyping or cancer subtypes is incredibly important to guide treatment. And that maybe other conditions like sepsis or acute respiratory distress syndrome or any of those are similar in terms of subtyping or phenotyping being important. So part of this comes to a big trial that came out recently in 2019, okay? And it was by Seymour et al. Published in JAMA, and we'll put the citation at the bottom of the video. This is from the trial. It's kind of their work. But there's been lots of different trials on phenotyping in sepsis. And many of them look at different things like biomarkers or cellular, different immune cell activation or different clinical features. This one by Seymour et al., one of the reasons we enjoy it is because it looked at clinical features and only the clinical things you could garner from, we believe it was within the first 12 hours of presentation. So these are things that everybody should have access to in the clinical arena and things that you should have access to early in the course. And they looked at a ton of patients, okay, almost 64,000 adult patients with sepsis. Now it was retrospective. They did look back in time using the electronic health record and used machine learning. This is outside of our area of expertise or understanding, so we can't really comment on how robust this is, but they have this kind of incredible machine learning approach to this retrospective chart review. They then found 29 routinely available clinical variables. Oh, from the first 6 hours. We said 12 above. It was even less than that. First 6 hours in the ED. And then they looked at these variables to try to validate if there was distinct clinical phenotypes of these sepsis patients. So they used kind of complex, again, above our level of understanding algorithms to see if there was clusters of variables that would represent specific phenotypes of sepsis in these patients. And what they found was that there seemed to be 4 different sepsis phenotypes. Now, caveat to all this is based on one trial, okay? Take all this with a grain of salt. Don't take this and run with it as if it's absolute fact. This is very, very early days for this kind of stuff. But they did identify 4 different phenotypes. They called them alpha, beta, gamma, and delta. And they acted a little different. So the alpha phenotype was often younger patients, less comorbid illness, so less patients with diabetes and hypertension and cancer and heart disease, and usually their illness was mild. And what they found is that alpha phenotype, their mortality was 5%, so the lowest of the 4. There was then a beta phenotype. These patients were often older in age, had more comorbidities, and often had renal injury from their sepsis. Their kidneys were injured. And the mortality in this group was about 13%, so a little higher than alpha. Gamma had a higher degree of inflammation. Their inflammatory markers were kind of more elevated and deranged. And they also had a higher incidence of pulmonary dysfunction or lung dysfunction requiring oxygen therapies or mechanical ventilation. Their mortality was a little higher, but similar-ish to beta. So kind of this beta and gamma phenotype mortalities were similar, whereas alpha was the lowest. And then delta were the sickest patients. These were patients in shock requiring vasopressors. They had a lot of liver dysfunction, a lot of coagulopathy, or kind of microthrombi, blood clotting, bleeding derangement. And the mortality was the highest. It was about 33%. Okay, and they found that these phenotypes for them were repeatable. They could identify within those patients with sepsis that they were studying which one was alpha, beta, gamma, or delta. If we were to describe these a little bit more, because we think this is important, that the alpha phenotype, if we were to describe it more, again, were younger patients. They did not have a lot of organ dysfunction. They often weren't in shock, and they had a really good prognosis. They responded well to standard care, fluids and antibiotics. Antibiotics, ABX antibiotics. The beta, and remember, the mortality rate for alpha was about 5%. The beta phenotype, this was an older population, a geriatric population, and they had a lot of chronic comorbidities, chronic kidney disease, heart failure, heart disease, hypertension, diabetes, all that kind of stuff. And the dominant organ system that was injured was the kidneys. A lot of these patients had acute kidney injury and acute renal failure, okay? They had a higher frailty, they were older at baseline, and the mortality that they saw in these patients was often driven by their pre-existing diseases rather than kind of their quote-unquote sepsis in general. And their mortality, as we said, was 13%. Nope, up here, 13% for the beta phenotype. Okay, and then the gamma phenotype, these patients had a lot of inflammatory derangements. So they had high WBCs, high bands, high inflammatory markers, and their predominant organ system involved was lungs, respiratory failure. They'd have pneumonia or acute respiratory distress syndrome. Many of them required ventilatory support early. And these were patients that maybe benefited from more immunomodulatory therapies. Again, we'll need future trials. And their mortality was similar to the beta phenotype at 15%. Okay, but starting to see how these are a little different, right? These ones was more hyperinflammatory, more respiratory failure, more ventilatory support, whereas this one was more older, comorbid, renal dysfunction. A lot of their disease was driven by their pre-existing disease. And this one was young, healthy, not a lot of organ dysfunction, really good prognosis, just classical therapies. Then the delta phenotype, again, this was the highest mortality phenotype. These were the patients in shock. They had hypotension, high lactates, high SOFA scores. They had a liver dysfunction, high INRs, which is that kind of coagulopathy. They had an acidosis, metabolic acidosis, and they were the highest mortality, right? Their mortality was around 33%. Rapid decompensation was common. These were the sickest of the sick. And those of you that work in the clinical arena, you might recall kind of seeing these phenotypes, right? That patient who is really doing totally fine. They got sepsis, but they're going to be okay. Give them traditional therapies, they get better. Or that beta phenotype, which is kind of that older, frail, comorbid patient who's got kind of acute kidney injury and has got sepsis, and their progression of disease, if it does get worse, seems to be more so related to their chronic comorbidities. Or that gamma phenotype that's got that white count that's through the roof. Their inflammatory markers are high. They require early mechanical ventilation from things like pneumonia and respiratory failure. And then that delta phenotype, that multipressor refractory shock. Their lactates through the roof. They got liver injury, coagulopathy, acidosis. They're on multiple vasopressors. They often, unfortunately, succumb to their illness. Right? These are phenotypes that it seems like anecdotally we have seen. So the clinical application here is that one might help with risk stratification. We know that the delta phenotype has the highest risk, the highest mortality. Okay, they might need closer monitoring, earlier escalation of care to something like an intensive care unit. Tailored therapies is a really exciting future thing. There's not enough evidence right now to support tailoring therapies, but we should probably study therapies for the different phenotypes. There's some early evidence that maybe the gamma phenotype might benefit from anti-inflammatory modulators. The delta phenotype, with all that coagulopathy, may benefit from things like anticoagulants, right? They might have more microthrombi. Trial design is a future importance. Maybe you stratify by phenotype to clarify which subgroups might benefit from therapy. And then there's some discussion on resource allocation, but probably not a big thing for this discussion. But our most excitement with things like phenotyping is, could we tailor therapies, right? Do these act different when it comes to different therapies? Maybe one wants less fluid, one wants more fluids. Maybe one benefits more from steroids and one doesn't, right? Maybe one benefits from early mechanical ventilation and one doesn't. All these things are really interesting questions that might have different answers than has been classically discovered if we were to think about these interventions based on the phenotype that the patient is presenting with. We do have just a couple clinical vignettes to apply the phenotypes. This is just something that we thought was fun. It's very brief. Oh, we actually didn't even go in enough detail here. Well, you can kind of see it anyways. 32-year-old male with pyelonephritis who does okay. This is like that classic alpha phenotype. They're not on vasopressors. They get better in a day or two. They go home. Compared to that 76-year-old with heart failure, CKD, they got a fever. They got kind of acute kidney injury. This is that beta phenotype, that old comorbid patient whose inflammatory markers are relatively okay. They probably have some renal dysfunction. And if they get sicker, it's probably related to their underlying comorbidities. Compared to that 58-year-old male, they have pneumonia. They have a high white blood cell count. They're on mechanical ventilation. That's that gamma phenotype, right? That's that phenotype with high inflammatory markers, often lung involvement, who often ends up on mechanical ventilation. And that's compared to the 62-year-old female with urosepsis, that gram-negative bacteremia, that lactates high. They got coagulopathy, right? Liver injury. This is that delta phenotype. They're on vasopressors, the sickest of the sick, highest mortality. So that alpha phenotype, mortality 5%, beta was something like 13%, gamma was something like 15%, and then that delta was something like 33% mortality. Okay, so this study, obviously lots of limitations. It was retrospective, it looked backwards, it was observational. They used kind of electronic health record data. Causality was not established. This was all kind of correlation. There will be future studies on this that'll help us understand if there's causal. Phenotypes were not mutually exclusive or static, right? Do these change or progress over time? This just looked at within 6 hours. At 24 hours, do these phenotypes still stand? All that kind of stuff. And it's not yet integrated into the clinical arena, so this is all food for thought. Future directions, as we said, look at this combined with biomarkers. There's fancy things like transcriptomics, proteomics. All these are being used to phenotype in sepsis. Many of them are not clinically oriented right now, but maybe they will be at some point. Could you combine these clinical phenotypes and find that the proteomics, transcriptomics, or biomarkers also vary based on these clinical phenotypes? Real-time electronic health record-based phenotype alerts. This would be really cool if these phenotypes were validated, if these were real, because it was all on data that we had within 6 hours of presentation. So could we say, oh goodness, this person's got septic shock, but not only that, they're the gamma phenotype. So that's an interesting future possible direction. Targeted therapies is something we talked a lot about. Again, really exciting future direction for targeted therapies. And then at the end of the day, if this was a real thing, could you integrate into sepsis care pathways, resuscitation bundles, all that good stuff? So that is a kind of quick and dirty on sepsis clinical phenotypes based on this trial. There's tons of other trials out there on phenotypes looking again at kind of protein markers, biomarkers, transcriptomics, all sorts of crazy stuff. So if this is something you're interested in, let us know. We're happy to provide you with additional resources or even do future videos on it. But hope you enjoyed that. Subscribe if you liked the podcast, 5 stars. If you enjoyed the video, give us a like. Again, we'll upload some practice questions and study guide to our Patreon page. And we appreciate you. Stay well, keep learning. We'll see you next time. Hey everybody, and welcome to WhiteBoard Medicine. We appreciate you checking out the video. Here at WhiteBoard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before moving on.